Ladies and gentlemen, boys and girls, welcome to yet another exciting episode of the Indian Journal of Anaesthesia podcast. It's the 29th episode, and we have a special Editor's Insights episode today. We have with us two eminent researchers. One is Dr. Rakesh Garg, our editor-in-chief, who joins us from Delhi. And we have a special guest with us today, Professor Harsha Shanthanna. Professor Shanthanna is a professor in the Department of Anaesthesia and an associate member in the Departments of Surgery, Clinical Epidemiology, and Department of Kinesiology and School of Biomedical Engineering at the McMaster University in Canada. Apart from anesthesia, he had advanced training in chronic pain and health research methodology. He serves in various capacities at national and international organizations. He has more than 45 peer-reviewed grant applications, published more than 130 peer-reviewed journal articles, and 8 book chapters. I had to summarize the CV, which runs into probably 50 plus pages, and I thought this would be an apt introduction for him. Welcome to the show, Dr. Harsha.
Thank you so much, Murali. I'm really glad to interact with someone that I really admire, respect, and know him as a friend and a colleague. And thank you so much, Dr. Garg. It is wonderful to meet you in this fashion.
Thank you and welcome. So this issue, Dr. Harsha and Dr. Garg, is actually diving deep into research. Now, when I say diving deep into research, it's for young researchers, clinicians who want to do research, or researchers who want to advance themselves in the field of research. So we have some exciting questions, in-depth discussions coming up your way. But before we start diving deep, Dr. Harsha, I would like to ask you, now you are a seasoned researcher. You've been doing very high quality research and you've been involved in multiple international trials and your research methodology is quite advanced. Could you briefly explain why understanding research concepts such as, say, hypothesis testing, trial designs, efficacy versus effectiveness, it's all very difficult terminologies. Why is it so crucial to understand these for young researchers?
Thank you, Murali. I think it's a very important question. See, when we get trained as physicians in whatever capacity we work, we never are taught the way research happens, the language of research. And we assume that it is quite simple, straightforward, and it's a matter of comparing two things. But statistics is more like the grammar of research. It's like if you don't know research, the statistical part of it, it's like two kids playing with each other, not knowing the rules of the game, and in the end, argue about who won the game. Not many know, where the way we think natural phenomenon where we apply, for example, causality of one particular thing causing the other, we assume that it's easy to prove, but in the fact, it works the opposite way. We can never prove it directly. So we rely on statistics to give us some important tools, assumptions, based which we make, and the rules we make, we set certain ground rules, and then we decide which won the game or which was better or which was associated with another. If not for that, all of our understanding or perception of what has happened with our experiment is totally flawed or is potentially flawed if nobody can prove it. So that's as simple as that I can put it. Honestly, my own experience in going through my research methodology training was an eye-opener completely on every step throughout my training.
Let's to talk about, a little bit about this hypothesis testing, trial designs, and as I mentioned, the efficacy and effectiveness. You did mention about statistics being the main thing, but how do these play a key role for people to get into research? Why is it so important? Understanding these concepts.
Yeah. There have been several experiments, just psychologically speaking, where they have looked at physicians or people who are extremely well trained in their own field and trying to just give them different versions of the same, where, for example, there is a relative risk versus an absolute risk. And people don't understand the concept of relative risk as much as they understand the absolute risk. For example, when you go to buy a particular item in a shop and they say it's 25% off, we naturally get excited and not knowing the true value of it. I mean, if you're ready to pay 1,000 rupees for it, yes, 250 rupees is a reduction. But what if it was costing 500 to begin with? So you don't know whether you're actually losing it or gaining in an effective way. So to put it very simply, that was a very simple example we go through daily lives. And that was just a matter of a risk of relative risk versus absolute risk. But when we speak about, let us say, hypothesis testing, because that is the core of it all, I want to go back to my earlier statement where I made as two things can never be connected directly, meaning if we have, let's say, a randomized controlled trial where you're testing, for example, ultrasound to healing of bone, or let us say you take, for example, midazolam or diazepam causing sedation in a patient who has anxiety, and then trying to see if that is actually making that change, you're making an assumption that this particular intervention is making that change. But you can never directly prove it in nature. So what we rely on is what is called as a null hypothesis, where we say the reverse. We say, okay, let's assume that they're not effectively changing it, meaning they're not related in any way. So that is the null hypothesis. And we try to disprove the null hypothesis by putting out an alternative hypothesis. And that can be in different ways. But simply put, all we're trying to do is disprove the null hypothesis so that to say our causal hypothesis, whatever it is indirectly true. So that is at the core of all of the statistical experiments that we do. And then add to that different data, because data doesn't have direction. All it has is only values. In fact, if you don't give units to that values, it means nothing. It has numbers. So it's not just purely numbers that you're going to play with. You have a particular direction to the data. You have a particular unit to the data. And that is how you make clinical inference. So there are another aspect of it is there is a clinical hypothesis which you want to test. And that is what at the core of it is. For example, now we're seeing, Jupiter in the sky, going back when we did not have telescopes, and people would say, oh, that might be something else, in the sky. And we could have put out so many different hypotheses. That is all our hypothesis. And then you look at statistically to say how it works out. So in a science, in a medical field, in a similar way, we have clinical hypothesis where we could say ultrasound is going to cause bone healing in a patient with fracture, and let's prove it or disprove it. And then you put out statistics around it, and then you do the experiment.
Dr. Garg, you are editor-in-chief of IJA and you review countless research papers on a regular basis. What are the common misconceptions or mistakes you see researchers make when it comes to understanding these fundamental concepts of trial designs, hypothesis testing?
So I think when we get papers, if you ask me what are the few common reasons for rejection, probably the first will always be the novelty aspect. But the second most common remains the lacuna in the method section. And as Dr. Harsha was mentioned, it would be best to have the best data if we study the universe. But that's not practically possible. And that's what we have to select a population. We have to select a sample, and which Dr. Harsha is emphasizing. There is what we come up with hypothesis, we make some assumptions, and all these statistical tools are based on certain predefined assumptions. And when these are not specifically understood by the researcher, then whatever the data they collect will have some inherent bias or inherent inappropriateness in those data. And whatever the research question they have planned, it will not be answered by the method section they have crafted based on that research question. So these are the most important aspects during the planning phase, and they have to understand that what actually they are looking for. Definition of an appropriate research question, generating an hypothesis, and then a study design which answers that research question, and then using the statistical tool appropriately. And it is not the end. And again comes when we talk about the statistical significance versus clinical significance. Again, it's a big issue and it's a big understanding. Everything which is significant from statistical point of view may not be significant from clinical point of view, and vice versa also at times. So these all has to be understood. But the other point is actually they are not very difficult, though we have done our fellowships and we understand a little faster. But I can assure that if somebody spends some time, read certain papers and publish a few, they will be able to understand the basic aspects of it. And that is what is desirable from all the novice researchers. In the beginning, it may look difficult, but actually they are not.
Now, you mentioned about the statistics. One of the questions that many listeners might have is about the p-values, because that is, something significantly which gets highlighted wherever it's in discussion or when it's reported. Now, what are the key points there that should be kept in mind to avoid misinterpretation with regards to p-values? Because this is for the listeners out there. And as an editor, how do you assess the validity of the statistical conclusions?
So when we talk about validity, let me put the internal validity first. We'll talk external validity sometime later. When we say internal validity, we need to understand that whatever statistical tools they have applied, are they appropriate? Like sometimes we see that Google is like garbage. Whatever you put, it will show you many things. And whatever the statistical tools, softwares that we use nowadays, if you put some data into it, it will give some value, which Dr. Harsha was emphasizing also. And those values, if you apply a wrong test and it gives certain values, it will not have any significance. That's what we need to understand. A simple example will be when we say, if we see our data, whether it is normally distributed versus not normally distributed, whether they are skewed data which are available to us. And when we put some statistical tool, they have the assumption that this particular tool is for a data which is having a Gaussian distribution. So the first look will be, if I look on the data and look for the dispersion of this data, it will give me a clue that probably this data is not good to be Gaussian distributed, and probably something has to be done to make it either normally distributed using statistical tool, or we have to go for non-parametric test. So this is one aspect which we look for, that yes, whatever the values are coming up. So let's start, you mentioned about the p-value. Whatever the p-value is coming up, it is coming from a test which is valid for that particular comparison. So this is one aspect. Second aspect is when we talk about the p-value, p-value is just when I said in the beginning that we are taking a sample and we cannot be 100% sure. And we assume that usually conventionally we say that 5% of error will be acceptable to us, whatever we conclude from those things. And when we say p-value, it is that whether whatever is coming out, is it by chance? It is not saying that if you are say comparing say midazolam with diazepam for sedation, it is not saying anything that midazolam is better than diazepam for anxiety element, nothing. It will just give us some idea that this difference, which is being coming out of those statistical tool, is by chance or it is actually happening. So we have to interpret accordingly. But if we see the statistical tool, it has so many limitations into it, depending upon sample size, depending upon the dispersions, depending upon other biases which could be creeped in. So what we are looking for when we want to conclude something, do we have some other statistical tool which will give us a fair idea of the data that we have? And sometimes we start using other tools nowadays, and which is very common across the journals. And IJA is now, it's almost mandatory that p-value is not sufficient. We have to go a step ahead to say something that, yes, whatever was the research question is being concluded into the right sense. And the other terminology that sometimes we use is the confidence interval. Suppose it is a randomized controlled trial, we want to see that how much, if you ask me what's the confidence interval is, in a very, very broad and simple language, I would say that if a researcher has done one study, he will have certain values, mean standard deviation, and it will give a p-value. But if I have a statistical tool, and that statistical tool statistically do that study 100 times and give me certain values. So now there is one actual study, and there are many studies which the tool has done it, and then it gives me certain values. And then that mean will be having sometimes on the left side of it, sometimes on the right side. So there will be a range of it. So that interval is being depicted as 95% confidence interval. So statistically, I am looking for that if I do this study 100 times or 95 times, what would be more my values? So this means I am trying to approach probably not just a small sample, but I'm trying to approach maybe a little universe component of it so that I can be a little more sure. And this is what comes into your concluding statement when you say you cannot conclude just merely on the p-value. We have to look for those values also and interpret that whether midazolam versus diazepam or drug A versus drug B actually has some difference or not. And that is again a statistical tool. Say, for example, if I give a simple example, let's say a drug A who has a duration of action of say 5 hours. Drug B has a duration of action of 6 hours. Let me be the standard deviation maybe 1.5 hours for each. And we say the p-value comes out to be say 0.001. We'll say that obviously the drug A is shorter acting or drug B provides a longer analgesia duration as compared to drug A. But if you put a 95% interval into it and statistically want to have this interval into our reporting, and then we get a value which is say somewhere around 3.5 to 5.5, 95% confidence interval. And on the other side, it is 5 to 6. Then we are not very sure that actually there is some statistically significance or the drug B is actually better than drug A, because we are now not very sure that actually the one drug is better than drug with regards to the primary outcome that we are looking for. I'm just saying it very grossly because people who are listening to us, maybe the novice one, but those who are advanced researchers, they can interpret it in more different way and they can be more different examples of it. So this gives us significance that we have to start using statistical tool more appropriately so that we can interpret the data that we have collected into more advanced way and we can conclude something out of it. And this will again, when we say the validity, internal validity is actually the strength of the method section that comes into picture. And when somebody, I will say in a very broad sentence, when I can say that this study appears to be internal valid. If I do a study at my center and I have described everything perfectly fine, taking off all biases, recordings, data collection, everything. And if I ask you to do it at Bangalore, in your institute, Apollo Hospital, Bangalore, and if you are able to do it exactly in the same way which I have done it, this means my method section was so strong, so objective, so descriptive, it gives the validity of the study. So this is what we are looking for. And if we add on the statistical tool that we discussed and which Dr. Harsha was also mentioning in the beginning, if we understand our research question appropriate, hypothesis appropriate, turns into a robust method section, apply the appropriate statistical tool to it, and interpret accordingly, probably we'll be having some conclusion from our study.
Excellent. I mean to say that was, yes, Harsha.
I think Dr. Garg explained it very well. I just wanted to add two things about type 1, type 2 error, because we spoke about null hypothesis and p-value is kind of linked to that. And that is why I would probably want to complete that just to get a sense for the audience. Now, let's say we're looking at the hypothesis and we say, if we take the example of midazolam and diazepam for sedation, for example, or drug A, drug B for pain relief for that matter. And then what we're saying is drug A is better than drug B, but this is a superiority hypothesis where we say that is what we want. Clinically, we think this new drug that was discovered, just came out, is better than drug B. And then we put out, we can never prove that. And we say, okay, the null hypothesis is that they're equivalent. There's no difference. And the superiority hypothesis is that the other alternative hypothesis, right? And then when we do the experiment, we should never lose of the sight that you have a small sample of maybe 100 patients or 1,000 patients, but it's still not everywhere. You're going to claim at the end of the experiment to the whole world that, look, guys, drug A is better than drug B. You can use it in Sydney, Australia, or you can take it to Bangalore or Ames, Delhi, or in Canada. But drug A is better than drug B, right? So that is that we should never lose sight of it as an experimental researcher. Now comes the play. Now, when you start the play, you can always know there is by chance. What you're doing is you're doing observations. You can never know. So you are relying on your observations of how you want to say drug A is better or drug B is better, which means you're going to ask the patient for pain score, or you have a sedation tool for diazepam, midazolam, and, for example, if somebody knows which drug has been given, midazolam or diazepam, and they think that midazolam works better, they might just observe, okay, you know what, midazolam, I know it works better, and they start unconsciously biasing the result. It affects the validity, meaning it's no more a proper experiment that you wanted. Similarly for drug A in pain relief. And what we're trying to do is control all of that and say, okay, you know what? We don't want false positives where we're going to falsely claim drug A is better than drug B. Or we also don't want false negative where null hypothesis is falsely rejected. What we mean by that is, if you're doing false positive, meaning you're indirectly claiming drug A is better than drug B, you're rejecting the null hypothesis, which was actually true, meaning it was not different, but you're going to claim it is better. On the other hand, it is actually better, but you're saying it's not different, which is false negative. So you need to control these two on the sides. So one thing we assume is how much can we give the false one error, which is more common. It's more common to say something works better than the other because of our biases and how the design we make the experiment. We typically say it's 5% based on this Fisher who gave out this, let's assume, guys, 5% is good enough. So you can take 10% or you can take 2.5%, whatever you want. But statistically, the whole world revolves around this rule of thumb where we go by Fisher's rule. Let's assume 5%. So 95% chances are that your experiment will hold true to what you assume. And there is 5% chance to do this instead of you, which when you roll a dice, 5% chance has the play. So that is what Dr. Garg was earlier saying. But we have to remember when we say P of value of 0.05, if it's equal, or P of less than 0.0, like if it's 0.051, you're going to say, oh, it doesn't work. But the experiment is not like that. I mean, maybe your sample that you took out of this whole world, 100 patients, there were few patients who are more susceptible. You should never lose of the sight. So you should always sit back. So that is where p-value doesn't add much. The second thing, as Dr. Garg was saying, is p-value does not have units. All it says is 0.05, 0.05, 0.05. So confidence interval actually has units. And if it is a wide confidence interval, you're going to say it's a small sample size, your p-value can always change. And that is always emphasized that you have a p-value and confidence interval. If you don't want to create p-value, it's not even needed. But confidence interval is really needed when you publish the results. The third thing I want to add is the fragility. There is something called as fragility index now. It more so applies, we can also do this for continuous outcomes, but it is more so for discrete outcomes where you have relative risk or risk ratios. For example, if you have a small sample, let's say 20 patients in each group, ESP versus interscalene block, shoulder surgery, and you are looking at success or pain relief. And then in the ESP side, it was 15 out of 20. And in the interscalene group, it was 18 out of 20. There was only a 3-point difference. But if your p-value is significant, but add one more a numerator or denominator, if it changes, then the whole p-value becomes non-significant or significant. That is the fragility of your experiment. Just by adding one additional numerator, if it changes the whole experiment, so you can actually have fragility index for all that you do or for any population or any kind of intervention. And you'll see the lesser the sample you have, because you're seeing less of the world, the more fragile are your results. So one is a p-value, the second is a sample size. But at the same time, if you take a large sample size, which is on the other side of fragility, there's always more. Just because you have so much data, you can come out with so many p-values less than 0.05. You don't know which one are clinically significant. So there, people start thinking about, okay, you got to then set a different bar. Let us set p of 0.025. Or, for example, people do this experiment. We come back to this drug A versus drug B. They'll think, okay, I want drug A to work. And they'll collect 10 different pain outcomes after 6 hours, after 12 hours, after 24 hours, after 48 hours. And then you see all these pain scores. And then at the end, they conclude p-value at 48 hours after that was 0.05. It works great. Well, you did 5 different tests or 10 different tests. So you are actually doing so many different tests. Your p-value is not 0.05. You're actually diluting your false, we call it dilution of alpha, or your false positive rate. Purely by chance, your p-value, if you do 5 times, for example, your hypothesis testing, 1 in 20 times, your value can be significant, statistically speaking. So the 3 things to keep in mind is, one is a sample size. Second is the fragility of the built around the sample size. And third thing, which I emphasized just now, is multiplicity. So the more number of tests you do, which we kind of don't know what happens, your risk of false positive error increases. So you should always say in your hypothesis, when is your outcome testing going to be? If you're doing more than one testing, you have to correct your false positive rate for it.
If p-value was a person, he would have felt very happy because we discussed so much in depth about it. Now, yeah.
Just a small thing. I think sometimes, which Dr. Harsha is emphasizing, if I put in a very common parlance, this is something called a data dredging. So it's something like if you force somebody to repeatedly the same question, and sometime he will confess, yes, he has done something wrong. So same thing happens with data. If you apply them multiple tests, or sometimes if you do a subgroup analysis, it will give you some value which will be less than 0.05. So this type of, I think, misuse of the data analysis should be avoided until unless it is a priori decided and your sample size is appropriate for it. That is a different issue. And that's why specifically for the randomized controlled trial with a single research question, we usually say that look for a single research question. Based on this, we are looking for the sample size. And Dr. Murali, if you allow, can I ask Dr. Harsha a question, because he has raised a very, very important point, with your permission?
Please, yeah, please.
So, Dr. Harsha, you mentioned about type 1 error and type 2 error. And you also mentioned conventionally, we usually look for type 5% is acceptable and type 2 20% is acceptable conventionally. How do you decide that 5% is acceptable for across the studies? Because even say type 2, and when you say power of 80%, do you think there are certain scenarios, if you can just say by example, where we say, no, alpha 5% is not acceptable to me. Let me reduce it to 1%. Let power not 80%. Let me come to 90%, 95%, making the type 2 error to be, say, less than 10% or 5%. So how do you decide that how much type 1, type 2 error is acceptable for this research question, and whether should keep it conventionally 5% and 20% or less than that?
Yeah, I think it's a very valid point. Now, there are certain rules where obviously if you can go against the convention of 5% or 20%, people will question it. For example, if you take 5%, if I take it as 10%, no journal is going to accept that. because I am saying, okay, you know what, I want chance to play more role. So that is on the other side of things. So usually you consider less than 0.05. That brings up the question of why are you doing it? For example, maybe you are looking at a study where you are using an anti-cancer drug, right? And there are a lot of side effects. And a company has given you, like, you know what, I'm going to give you, thousands of lakhs, and I want you to do this, run this trial. I'll be neutral. I'm not going to influence it, but I want you to run this trial. And yes, you're going to randomize 100 patients with breast cancer or any cancer for this, and you don't know the drug side effects. And meaning in phase 2, they would have said, they can have a lot of nausea, vomiting, somebody might die, somebody might have other sort of skin cancers, you don't know because of immunosuppression and all that. But then you're thinking, I can't just run this test because I don't want to expose my patients to all this. So in between, I want to really look at the side effects. So what you do is you create boundaries for what you call as multiple testing, where in between, you're going to have a drug safety monitoring board. We call it DSMB. And you're going to have them look at the data blind. You don't, meaning nobody knows. They will have the data as to which is drug A, which is drug B. You don't know. And they will see drug A is actually causing more problems. And then they might want you to change the dose, or they might want you to say, stop the experiment because it's too dangerous, or change it in a certain way. We call it adaptively randomizing it or adaptively allocating it. Or they might say, or you might want to look at the data and then create subgroups, because one of the drug is actually doing, one dose of the drug is doing better than the other. So what you're doing is effectively doing a testing, which we said earlier about multiple testing. You're having a look at the data in between. So then you'll have to use your alpha. We call it alpha spending. So you have to spend some alpha for doing that test before your whole experiment ended, right? So this is one example. The other example could be where you have a very large sample. For example, there is an international multi-site study, 10,000 patients, and then you have so much data, as I was saying earlier, statistically, 0.05 is a big margin for statistical significance. So people usually say, let me have so much power in my study sample because it's so large. Let me take a much stringent alpha, which is 0.025, somewhere around that. So this is a very common sort of approach to reasoning your alpha. But you can have an experiment where you say, I have so much confidence in my drug versus the alternative comparator that I'm ready to go with 0.025, right? On the other hand, beta, which is the false negative error rate, which you consider to be around 20%, set at which you have 80% power, which is 1 minus beta is 80% power for a study. Conventionally, look at sample size, we tend to actually have more power because you're okay. You can go up to 90 or 95, whichever way you want. People, the other thing about sample size, I know we're not discussing it in a direct way. Even if you ask the best, methodologist, Gordon Guyatt, who is considered the evidence-based medicine father, he says sample size is pure nonsense in one way to look at, because it depends on how much money you have. It depends on what is your outcome. It depends on what you're doing. At the end, you want to please X, Y, Z, including the journal. But at the end, you also want to defend your sample size. So as much as it's arbitrary, power is one factor which influences your sample size. So, for example, if you're doing an experiment, we'll come back to the drug A versus drug B, and with a power of 80%, you got per group sample of, say, 45 or 50 per patients per group. And for a power of 90%, it could be 70 per group. So I would be more confident if it's not, if it's a common, perioperative trial, I would go with 90% power. So I have more power to say, there is less chance of false negativity. On the other hand, if it's a very rare condition and you're going to use drug A, drug B again, if for 80% power, if your sample is 460 per group, and then for 85% it is 675, or you're saying, you know what, let me be okay with 80%, right? So there is a big difference in what you're trying to do. So traditionally speaking, when you look at sample size, you have to ask, or you have to put it in a table where you have all these factors: alpha, beta, what is your effect size, how much are you expecting? These are the three variables. And then you see, okay, I have slight changes in alpha 0.025 or 90% power. And then you pick what is most feasible. So these things also change how much sample you need. Hope I put this all together.
Absolutely. I think a very important point is coming up, because people usually think, though the conventional is 5% for type 1 and 20% for type 2, a power of 80%. But yes, you absolutely emphasize that it is somewhere, when we talk about alpha, it's rationing of the alpha needs to be done depending upon what research question are we answering. And what a priori we have decided that whether we'll be going for an interim analysis, if it is DSMB who is looking for the adverse effect, and especially when a drug has come up being used and it has some adverse events which is catastrophic and we don't want to take a chance, probably it will shift that type 1 error should be the minimum one. And on the other hand, it is a corollary if you talk about the Indian judiciary, which usually conventionally thinks that no innocent person should be penalized, even if they have to leave some actual criminals for the sake of evidence. So that's why they can be little more liberal on type 2 from even Indian judiciary, which is a conventional thing. And that's why 20% is acceptable. And on the other hand, the criminals should get something. That's where we are shifting towards the 5%. So I think in that parlance, we need to understand it. But as absolutely it is in continuity of previous said things, that we also have to look for other factors like the sample size and the other aspect when we try to look for those factors in addition to the complications, the adverse events, or if it's a new drug or a new technique which has some beneficial effect a priori we are thinking of, or it would have some incidence of complication which we absolutely want to avoid, don't want to give it for a drug which we are comparing. Thank you so much for emphasizing those important aspects. Dr. Murali.
Thanks a lot, Harsha, and thanks a lot, Rakesh. I mean, it was excellent in-depth discussion about this. Now, Harsha, a question to you next. There was an excellent editorial that you wrote in the recent past about non-inferiority trial. Now, this is something that confuses researchers, and many people have come up to me to get your number or get your contact details because they wanted to actually understand this more in detail. And one of the reasons this podcast idea was born is there's a lot of pressure to get you on the podcast to discuss this concept. So superiority trial, non-inferiority trial, equivalence trials. This is something that confuses researchers. Can you walk us through the differences and when should each kind of trial or, trial be used in clinical research with few examples?
Sure. Thanks, Murali. Again, I think as I was thinking, our previous question discussion, before I get to that answer, I really appreciate what Dr. Garg brought up. All this discussion, and when we discuss something like this, it's so much nice, right? So much information comes out. And what Dr. Garg said was, it's easy for clinicians with the knowledge, how much intelligence or they have to be physicians. These things are not difficult, but we should have some time to really learn this. If you don't learn this, you can never do evidence-based medicine. You can never, even for a physician not doing research, I think these are very important to understand. So I want to reiterate that, that's all, as we begin to discuss more interesting questions. Thank you. So we traditionally know experiments as superiority because that is what, again, by convention, even if you don't say it's assumed a superiority trial, right? We'll go back to this null hypothesis. So in the null hypothesis, what we said was that we have to do it indirectly. We can never prove something is better than, let's say, for example, we have, a kidney surgery or, laparoscopic cholecystectomy or an open surgery where, let's say open surgery, lower abdominal surgery, and you have a technique, let's say epidural, for example, and over time, what has happened is we have so many options, unlike previous times. So science has grown leaps and bounds. So superiority used to be the case when we never had something for a particular condition. Now, for most conditions, we know there are options A, B, C. And now what we're playing with is not really A versus B, but we're really saying, okay, how big of a difference is it? And medicine has also grown in most fields to an extent where, for most of the common problems, you already have something that really works very well. Of course, the very well part comes, you see, people, the other problem with any experiment, when you go, for example, if somebody asks you, okay, did you like this movie? You might say, yes, but you might like the movie for songs, but somebody might liking it because, there is Shah Rukh Khan in it or, some other actor in it. So what I'm trying to say is there's a particular outcome of a study. When we say one drug is better than other, until now we said better. We never said for what. What is it better? Is it pain relief? Or is it the duration of pain relief? Is it because it causes less nausea? Because these are all attributes of what you call as something is better, right? Now, medicine has grown to a stage where this better has to be one well-defined because you have to make options. For example, you go to a restaurant tomorrow and somebody says, don't go to that restaurant, go to this. And then you go and then you don't feel good. And that might say, I thought you eat non-vegetarian. That's only good for non-vegetarian. You should have gone for vegetarian. So I'm trying to drive the importance of what is the outcome here. Now, coming back to the fact that you have an open laparotomy and you have epidural as your, the best method of analgesia. So we call it best method because you can never get a better pain relief. That's our outcome, right? You can never get a better pain relief than that. Now, the reason we're talking about alternatives is epidural, it might be better, but it has other effects. And the second factor is you have so many X, Y, Z sort of techniques which have come out down the line which say, okay, here I am, you can use me, you can use me, you can use me, X, ESP, quadratus lumborum, or whatever else you have, tab block. But then as a clinician, you're trying to decide, okay, which is better now? Which one should I use for my grandfather or, this patient who has this? Obviously, this is comparative effectiveness in one way, which we could get later on. But in your heart or by literature that the alternatives are never that strong as epidural could be. So now when you sit back, your hypothesis was their null hypothesis is they're no different or one is better than the other. Now the question is, your tab block or ESP block or quadratus can never be better than epidural. Now the question is, how do you make it work? Why are you making a point to argue that I want to choose ESP or quadratus lumborum over an epidural? If you forget the statistical or hypothesis part, if you clinically think, how are you going to argue? I'm going to argue to my father and say, you know what, don't worry, pain relief is one thing, but you are going to walk the next day. You can't have an epidural where it might drop your blood pressure because you have a heart patient, or you might not be able to walk because epidural causes weakness, or if you're too afraid of needles when you're, going to your back. Now, these are all side effects, right? Now, how do you want to compare the side effects? Because these ones are not that common. So if you look at side effect incidence in a rate, it's very less. So you can't design a trial where you're going to compare hypotension or falling after epidural versus falling after, let's say, quadratus lumborum block. So then you start thinking, okay, let's just go back to pain relief and say, okay, I know my quadratus lumborum block or ESP block is not so good as epidural, but I know it can work. Are we ready to accept that it can work, but not so good as an epidural? So here is the crux of the problem. Now, why do we know about this is drugs, when they come out, for example, you have antihypertensives, you have so many, but it's not so much about their potency, it's about their side effects that they differ. Now, so that is why industry has relied a lot on all of these concepts of non-inferiority more so. Equivalence is not so common, but non-inferiority more so, where they say, what we're trying to say is, guys, this new drug for blood pressure is, we know it's not so good, but it's better in side effects, or it costs you less because, or like that. Similarly, if you come back to this example of epidural versus a different technique, you're going to say, okay, we know it's not as better for pain relief, but what is that as better? How much? So we're going to first fix an outcome, pain relief, and how we're going to measure. Is it number of patients, or in a particular patient, this is, so we're going to say how much is, I'm going to say it need not be good, but it should be good enough. So there is a margin. So it comes back to the core of it is all the non-inferiority margin when we talk of non-inferiority hypothesis. Let us say with epidural, I'm going to go slow because I'm going to talk about some numbers. Let's say with epidural, in a group of patients who have laparotomy, the decrease from epidural is going to be around 3.8 units in a 0 to 10 scale, which is a big unit. Meaning, if you don't give epidural and if you give other drugs, patient will have pain score which is higher than 3.8 in a patient, which is a big enough range, right? Now, if you're doing quadratus lumborum block in that group, and you're going to say, you know what, I know it's not going to be 3.8, but let us say, what if it's going to be 2.8? No, the difference is 1 between 2.8 and 3.8. Somebody might say, you know what, that is still a big difference. I want to still choose epidural because for me, 1 unit is a big difference. That might be true. So then you're going to choose a difference which you say most people agree it doesn't make a big difference. So from 3.8, let it be 3.4. So that difference of 0.04 is the non-inferiority margin. Now, what your hypothesis is that it's not going to be such a big difference, but that zone is 0.04 between 3.8 and 3.4, or let's say 0.05. Half a unit is what I'm going to fix as, I'm going to fine with losing half a unit, which means quadratus lumborum patients may have more pain than epidural, but not more than, that is the emphasis, not more than 0.05 unit. That is the non-inferiority margin. And see, we are not worried about, here comes the question is two-sided or one-sided. When we create null hypothesis, so Dr. Garg mentioned about Gaussian distribution, which is simply a normal distribution curve, right? It has one side, the other side, and one side says it can be inferior, the other side says it can be superior. Now, for non-inferiority, we can forget the superiority side. We know it's not superior, right? So all we're worried about is one side. So that's why we build a one-sided test. And we're going to say this side, boundary of that 0.04 is, we build a confidence interval around it. And that has to be within that confidence interval. If, when you do the experiment, at the end of it, if your 95% confidence interval margin exceeds 0.04, if it's beyond let's say 0.8 or 1, then your quadratus lumborum block is worse than what you thought. So it's not non-inferior, right? Which means your null hypothesis is true, your alternative is wrong. And on the other side, if it falls within that, then you're going to claim, guys, you see, I said it was less than going to be 0.04, which is fine. So that is the whole crux of non-inferiority thing. It's quite simple. At the heart of it is understanding why you're doing it, getting into an outcome that you're chosen, and choosing a non-inferiority margin with which you build a confidence interval on the one side. Of course, add to that, you can add, sometimes what happens is, if you are outcome or the comparator you've chosen is not so strong, then you can continue to get a superiority as well. I don't want to get to that. It's just an extension of a statistical analysis where you can do both sides and you can also show superiority. But simply speaking, non-inferiority is that margin. Equivalence trial has both margins. You're going to say it's not about showing inferiority, non-inferiority. It's saying that between this margin, I don't know if it's more or less. It could be both sides. And then I'm going to build a margin so it falls within that. And that is where we call it equivalent. The reason what I want to emphasize is when you do a superiority, for example, I want to emphasize going back to how we infer clinically after doing experiment in a superiority trial. Let us say you do a superiority trial and you couldn't prove the alternate hypothesis. People claim that drug A is drug B now is equal. No, I mean, it could be equal, it could be inferior. All your drugs say what they're not the same, right? So people claiming in a superiority trial that they're equivalent is wrong. It's just a bad interpretation or a wrong interpretation. In really methodological way, if you want to claim equivalence of saying this is as equal as that, you need to build a boundary like non-inferiority and you have to test that hypothesis. I don't want to emphasize too much on the equivalence trial because they're not so common. They're in fact quite rare. But when you understand non-inferiority, that becomes an extension of understanding it.
So I had a few doubts when you were talking about the non-inferiority trials. Are there any clinical settings where you would caution against the use of non-inferiority study design? That's my first one. Second is, if you were to have, say, non-inferiority margin where the success rates of both the techniques are high, like example, you said, let us take epidural and quadratus lumborum. What if quadratus lumborum also is working very well, in most of the patients, and epidural also is working very well in most of the patients? So when the success rate of these two interventions are very high, how do you design? Now, it's easy when one thing is not working well, but if they're very close to each other, how would you kind of design one? And finally, I would say, how do you calculate the sample size when it comes to such designs?
So non-inferiority trial is complex in a few ways, in the sense, or rather put it this way, we will talk about that probably when we discuss explanatory or efficacy trials as well. But basically what I mean to say is, the design of a non-inferiority trial, I emphasize a lot on the outcome. And I gave an example of thoracic epidural and quadratus lumborum. Pick thoracic epidural is very important. Similarly, whenever you pick a condition, a patient with a particular condition, you always have to have a standard therapy or a standard diagnosing thing. That is your high bar. That is the gold standard, right? And that has to be one considered and selected so that you are saying the other is not as good, but good enough. That is a part. So your comparator, the second part is a comparator. First, we talked about the comparator being the gold standard, and the second thing is the intervention. Yeah. So the intervention you're testing must also have demonstrated efficacy against placebo, which means, for example, if you say some block cures cancer or stellate ganglion block aborts cardiac arrest, right? I want to test that with, against another technique where you prevent cardiac arrest. Well, how much evidence do you have to say stellate ganglion block will prevent cardiac arrest? There has to be some efficacy of this shown versus placebo. Similarly, we come back to this quadratus lumborum block. We cannot just take a method and say, okay, I know this works. This has to have proven against placebo, because in the end, what you're claiming is when you do nothing, which is placebo, and then you do something and the gold standard. If you are not considered, if your non-inferiority margin is too wide, for example, you say, we considered 3.8 and 2.8, for example. If it is so big, then by chance alone, even in patients which are placebo, where they don't give quadratus lumborum block, but they get nothing or just oral analgesics, that might give you as big a difference, which means you're ultimately going to end up saying epidural is as good as doing nothing or standard of care. So one thing is to make sure your assumption of comparator has proven efficacy against placebo. If you have not done that, you have to have a placebo in your control group. Like you have to do a 3-arm trial where you're going to once show that your new comparator, which is quadratus lumborum, is better than standard of control placebo. And that is not inferior to epidural, because you're going to show, your experiment is going to show the ultimately at the end of the treatment, epidural is so much better than doing nothing, which is you already have a control. And your comparator falls in between, and you're going to show it's non-inferior. Because if you don't have that, we call it in pharmacological terms, we call it assay sensitivity. Assay sensitivity. So what do you understand by assay sensitivity is that in a new experiment, it is so much better than this. So that assay, meaning that difference from placebo to this, you must have that difference. If you don't have that difference, the assay sensitivity, you lose that. So in non-inferiority trials, it's very important that you have that assay sensitivity, and if you don't, your other question was, what if both works, right? I think that was a question. Now,
both are got good success rate, and both are very good.
Yeah. See, success rates, when we look at success rates, it's a different way of looking at the outcome. So when we look at research as such, you have data as such, you have continuous outcomes and discrete outcomes, which are yes or no, success rate, and how many died and how. So in general, continuous outcomes like pain scores or temperature, all of these pack a lot of data because there's so much data and you're not losing it. So at the same time, they're average to a group. It doesn't say how much an individual does. So there is plus and minuses. Similarly, for success rates and discrete, it is how many individuals. So it puts together all individual, but at the same time, there is not enough data within that. So you need a large sample size, right? But interpreting success rate like non-inferiority margin is the same. You have to build a non-inferiority margin where you assume, if, for example, if an epidural success rate, let us say, for example, another good example is laboring a woman and you have an epidural with opioids, let's say, okay? And how many women at the end of the labor, say, had very good relief? Let's say it was 95%, which is success rate. If you have another group, comparator, where you're going to say, I'm going to avoid all opioids, I'm going to just go with pure bupivacaine. It's a very good example, clinically speaking, and someone can do it if you want. And then you're going to say, opioids got a lot of side effects. My pregnant women have a lot of itching, they have nausea, vomiting, and I want it less. So you're going to say, even if it's 90% successful, that's fine. So your non-inferiority margin is 5%, right? The difference between 95% success rate where you use bupivacaine with fentanyl as an opioid mixture, which is a standard, and then now you're going to say, I know epidural works, pure plain bupivacaine, so you have good assay sensitivity. I hope I'm clarifying that. And now you're going to say, my success rate need not be 95%, it can be 90%. And that 5% margin is your non-inferiority. And at the end of the experiment, if you're going to say, show your confidence interval builds within that, that's it. So that's good enough.
Good example. Thanks a lot. I mean to say, this is a wonderful, detailed explanation of the non-inferiority trials. I'm sure all researchers listening to the podcast will gather a lot of insights from this. Thank you. And if they want to know more about it, I think I would probably refer them to this wonderful article that you've written. It was in BJ, if I'm not mistaken, right? British Journal, yeah. So, Dr. Garg, we have been silent for a while, nodding your head. So let's get you to speak something. From an editorial perspective, how important is it that researchers clearly define their trial design?
This is absolutely very important. And Dr. Harsha has brought very important points into his clarification also. So when we have a research question and when we generate hypothesis, each research question based on what are we going to prove from that research question has to be answered through a specific research design. I'll just say you a simple thing. Now say a new technique has been developed or which is an emerging technique, and there is already an existing technique which is doing very well, like the facial plane blocks which are coming up. Now we want to compare it. So if somebody comes up, says a Dr. Murali's technique of a facial plane block, he had just designed it based on his experience. He doesn't have a data. So it has to be probably a case series, or when he is doing it, probably today we'll say, do it on a cadaveric studies and then proceed with the human studies. And when you do it, it will be like a case series. So it's study design here will be a couple of cases where you have done it. Once you have it, you have proved something. Now you want to compare it with something which is standard of care or sometimes a gold standard. Therein we require sometimes a randomized control trial. Now, if some technique has come which is absolutely novel, which is path-breaking, and you think that the older technique has to go out, but you need some research, then probably it has to be something which probably you will go back, because in one group you cannot put the patient for a technique which now is redundant and cannot be accepted just for the sake of research. So probably you will go back and you will try to match those new technique with patients which you have done earlier and try to match them. I will go back and do a study. But if you have something which we have just discussed very nicely, the equivalence trial and the non-inferiority trial, we are looking for certain techniques. For example, we know that even today, the epidural block is still the gold standard for many things. And when we go for, say, facial plane blocks, whatever you say, maybe a quadrantal lumborum and so many facial plane blocks, therein because if the patient is in certain coagulopathy, if patient is into sepsis, if patient is undergoing liver disease, where you think putting the epidural catheter into a central neuraxial area will be a little disastrous. And if you put up a facial plane block, which is even giving a duration of analgesia or decreasing the drug of analgesics by say 5% or 10%, probably you will go for it because the complication rates are much lesser in this newer facial plane blocks. So this means based on your research question, you have to pick a specific study design. And this is very, very important. If something can be compared in an RCT, which remains on the highest end of an individual study patterns, it has to be an RCT. Otherwise, if you want to have some new data, some new ideas, it could be a retrospective analysis based on your experience. If you want to compare and go back and see, you can have a cohort study, you can have a mass control study, sometimes a propensity mass control studies can be done. And sometimes you want to look for many factors. It could be a prospective observational studies also. So as a researcher, it is very, very important to choose your study designs very appropriately. And I'm very happy Dr. Harsha has mentioned very clearly, and this is a very common question. When we put up the groups into the study designs, 2 study groups, 2 group study design, or 3 group study design, when to choose a control, when not to choose a placebo, because nowadays we say placebo should not be chosen for studies. If there is some standard of care, they should not be denied for something. So based on the research question, which Dr. Harsha has mentioned, you have to decide that what will be your group distributions, 2 group or 3 groups. And based on this, again, you can look for the study design. So I think if we understand our research question best, if we can understand our clinical scenario best, and if we know the review of literature best, that how they are performing as per the evidence, we can always choose the right study design.
Thanks a lot. Now we'll move ahead with different types of trials again. Dr. Harsha, you were mentioning about efficacy and effectiveness trials. You just briefly mentioned. Now, these are the terms that are often used interchangeably, but they mean quite different things with my basic understanding of these trials. Now, could you explain a little bit with examples, of course, the difference between these two and why it's important for researchers to understand the difference?
Thank you. So, efficacy in simple ways to understand is that something works, right? Now, you have to, when you say that something works for a particular condition, you have to compare it against placebo. Means nothing, at least for that particular outcome, right? It doesn't mean that you give nothing, but the biological action of it. Let us say you come out with a new block and it stops headaches, right? And then we cannot, as scientists claim, believe in me, this is a new block, it's going to work. But people are obviously going to question, okay, how is it going to show headache? Headache is such a big problem, right? We've done so many things. You can't just claim something like that. And we know people claim all sorts of things, right? Now, the first thing to show is that it works. Not against something, not against the comparator. Biologically, does it work, right? That is an efficacy trial. For example, if it's an antihypertensive trial, the drug has to show it works. Similarly, people say we can use ultrasound for fracture healing, or artificial intelligence, or virtual reality works very well for sedating patients or pain relief for patients who are in labor. Yes, there is evidence. But if you come out with a new tool tomorrow with just a program with glasses and say, but you still have to show efficacy that works. So that is the primary meaning of saying something is working, so that we believe it's biologically working, the biological plausibility of something works. At the same time, you have, when you try to show that, imagine yourself showing, okay, this is my block, this decreases headache. And somebody might say, okay, let's bring all patients of headache, 100 patients. And then you say, hold on. I don't want migraine. I just want occipital neuralgia. Yes, cluster headache is fine, but not migraine. So what you're trying to say is, biologically, my block is not going to work for all the headache patients, guys. Hold on. Let me first show that it works biologically for the mechanism of headache. Okay, for which I'm going to say, you could say migraine, which is more common. Cluster headache, let's reverse it. And I would say, okay, I've got this great block, works for migraine. And then people are going to say, okay, let's get patients, and somebody will say, let's get people aged from 20 to 60, 80 and all that. And then again, you're going to say, no, hold on. I don't know if it works for beyond 50. I've only tried it in phase 2 experiments where more than 50, they have so many different kinds of headache. It's all confounded. So okay, let's select this. Okay, let's select from 20 to 45. That's all. Okay, and then you're going to say, okay, guys, you can't give it like you want to do a multi-center trial, and you will say, okay, let's bring together all of you, because the block has to be done in this way. You have to choose a 25 gauge needle. You can't go more than 2 centimeter, and then you have to inject 10 mLs. The reason you're doing this, I'm trying to be sort of funny here, but at the same time, trying to emphasize the granularity of trying to show something works. Because after all, at the end of the experiment, you don't want saying, guys, you used a 22 gauge needle. I said only 25 gauge needle. No, I'm just making it funny. But efficacy relies on these parameters because you really want to show this works, right? It's a very simple thing, but the concept is it has to be valid. At the core of it is all, in a study, you're trying to say it is internally valid. What do we mean by study being internally valid is it shows what it is supposed to show. The question marks at the end of the study is only that 5% chance. Everything else, because for example, if you go back to that and you did the study and some other, in a multi-site study of this efficacy trial, 2 sites added patients who are not migraine, and then your study fails, then you're going to question that, right? You have to have a validity, which, because your validity says in this group of very strictly controlled population, strictly given this and strictly observed for pain relief, and exactly at 2 days after the injection, this works. Okay. So this is a very strict definition, or I won't say strict, but one end of what is called as efficacy trial. Usually this spectrum of efficacy and effectiveness, they're not at two dead ends. They try to be in the middle. We try to say which side they fits into. Now, let us take an effectiveness trial. Now, for example, occipital nerve block, we know it works for so many conditions. And you will say, my technique for this occipital nerve block using ultrasound, given twice or in two places, works better than in a different way. Now, what you're trying to show is not that it works or not against nothing. All you're trying to show is better than the other one. So this is effectiveness. In US, the term comparator effectiveness is very commonly used. You're comparing two things. You're trying to say which one works better, right? So that's all it is. What tends to happen in comparator effectiveness, or the effectiveness side of the spectrum, you lose internal validity a little bit, depending on how you design experiment. But you gain external validity. So I introduced the term external validity. What does that mean? If everybody in the world only looks at doing your experiment as internally valid, only people in that population, only people who use 25 gauge needles, only they will be benefited. The rest are all going to say, I can't use it, guys. So the external validity is, as much as it applies to so many different population, it is better. So which means for example, going back to this occipital nerve block example, it can be used for any patients with headache, let's say from 20 years to 65, or migraine to this. Then externally it is very valid, which means it doesn't depend on how you do the technique. All you need to do is a little bit of skill. For example, if you have to remove an appendix, you have to remove an appendix. If you don't do it, it's not an appendicectomy, but you can do it this way. You can do the appendix and then wash it out, and then you can, do an antibiotics this way, or put your dressing this way. That all doesn't matter. So you have a large external validity, which means it can apply to so many different areas, or in practices and things like that. So the spectrum of efficacy and effectiveness, internal validity and external validity, are all kind of combined together when we understand these concepts. I hope I made it clear, but I'm happy to explain it.
That is excellent, actually. The entire spectrum, what you mentioned. That the other terminology, I think, which again confuses people, is explanatory and pragmatic trials. Now, these are all, words which are floating around, which confuses people, especially researchers. So what is this? Now, could you explain the difference between this?
Actually, it's almost synonymous in a way with efficacy and effectiveness. So an explanatory trial is trying to explain in a very stringent condition where population, everything is selected for that it works. So that is an explanatory trial. For example, if you're doing a ESP block for a condition which has never been tested, but it's biologically plausible, then you really want to show that it works. So you're doing an explanatory trial. But on the other hand, you want to do a pragmatic trial. Pragmatic means being pragmatic, knowing that in the whole world, you have so many factors that come into play. When you're doing ESP, somebody might do it with less skill. Somebody might do it with a transverse approach. Somebody might do it with a longitudinal approach. Ultimately, what matters is the drug has to go under the erector spinae. So you're going to not control your parameters of how you select patients, or you're not too bothered about, or you might also have a wide outcome collection. For example, the patients might be coming to follow up at, say, 6 hours afterwards, and somebody might come at 10 hours afterwards, and you're going to create a window and say, I know it works. I'm going to give it a window of 6 to 10 hours, because pragmatically, I don't want to call everyone at 6 hours. Somebody might want to come at 10 hours. I'm okay with phone follow-up versus, in-person follow-up. These are all questions of pragmatism where it works. At the same time, pragmatically, you're designing a study so you don't lose lot of patients for loss to follow. When you're designing a study, which Dr. Garg earlier mentioned, you have to keep all of these into consideration and see what are you going to achieve in the end. And does your trial fall between explanatory or pragmatic side? For example, what happens is when you design a study and then you're collecting patients, suddenly you realize you're not getting enough patients. And somebody might say, why don't you change your exclusion criteria, include patients with BMI of 30.30, let's say 35. And you're going to think and say, you know what, I'm not sure. What if the ESP works or doesn't work? And, it might be difficult. We have faced that question earlier, where you're going to see pragmatically, all my patients are above 35. But how is it going to find whether if it doesn't work, is it a question of explanation or is it a question of being pragmatic? Am I going to lose more patients and yet being able to recruit so many patients in this part of the world? That's a good example of we face a challenge. How do you decide between going towards more explanatory spectrum or going towards more pragmatic spectrum? Sorry, Dr. Garg had a point.
Yeah, absolutely. I think this is an important aspect to looking for explanatory versus pragmatic. It is as simple as ideal world versus real world. So yes, we want idealism to a certain extent when we do a study, but then finally the conclusion has to come in the real world and we have to use it. And this is when we plan a study and when I look at as an editor-chief, I looked at what are those inclusion and exclusion criteria. And if you just go back in the timeline maybe say a decade or 2 decades back, we used to get studies, the patient who are diabetic, hypertensive, any psychiatric disorder, communication gap, having chronic pain or something were excluded. But if you exclude nowadays those patients from your study, what would be your applicability of the outcome from your study to the real world? And that's why Dr. Harsha mentioned that we have to look for little more pragmatism into this aspect. But simultaneously, we also need to understand that if those parameters which you thought earlier to be excluded, now you are including into a study, into so-called pragmatic study, are they influencing the primary outcome directly? Sometimes we use the terminology called as bias and confounders, basically confounders. You have to include into your method section, and which Murali has asked me earlier also, that the methodology should have certain aspects into it, that if we think that those pragmatic parameters are influencing the primary outcome, and if it is a randomized controlled trial, they have to be balanced in both the groups so that they do not influence the outcome. And we have to use the statistical tool accordingly. So this means when we plan a study, again, we need to understand all those parameters which can influence your outcome, and they need to be considered appropriately into your method section. And sometimes you have to use statistical tool to look for whether those parameters has affected your outcome in certain senses. So this means when we move away from the ideal world to the real world, we have to understand a lot when we try to conclude from your study. But yes, nowadays we are looking more for a pragmatic study rather than just simply the experimental study, because we want to extrapolate those outcomes into the real world. Dr. Harsha.
Thank you, Dr. Garg. I think it was a very important point about confounder. I just want to give an example because we are doing this trial right now, and this is a good example of it. Chronic post-surgical pain has gained a lot of importance over so many, at least the last decade or more. And when we looked at chronic post-surgical pain, we thought, surgery starts everything, and we have such a nice experiment where we can start with patients and then we realized we still don't know why it causes. And the two biggest associations, at least in this part of the world, come from patients who already have pre-existing pain, either in the site of the surgery or anywhere else in the body. And you know what happens? They're all excluded in trials which do interventions on chronic post-surgical pain. Now, the question is, guys, where did it apply for? So if you do a trial where you're excluding patients who had these risk factors, who predisposed for chronic post-surgical pain, where is your intervention going to be applicable for? So this is a very important explanatory part. So what we are doing, and I think pragmatically this is what happens in the real world, You can't exclude them. So you have to, one, balance them, right? And secondly, when you say maybe your intervention, you don't want to, under dilute your intervention in the way you show it doesn't work. So what you can always propose in your study a priori is that you can do a subgroup hypothesis. You will say, you know what, I'll include all this, okay? And then I'll balance them. I'll try my best to balance them. Again, if you do a 50-patient trial, it's very likely you won't balance them because there might be just so few patients. If you do a large enough study, you will see that they get balanced. And you'll also be able to do a subgroup hypothesis testing where you do a main hypothesis testing and say, let me take out all patients who had pre-existing pain and see how it works. Maybe your ESP block or whatever XYZ block helps patients who don't have pre-existing pain but does not do much for the pre-existing pain. At least now you kind of know an exploration of what happened. So this is a good example I wanted to just put out.
So I think with Murali's permission, I think,
Please.
Harsha, I think in the beginning, I said somewhere that we should not be doing data dredging by not doing subgroup analysis. And just you mentioned now when we turned up to pragmatic studies, you said, let's do a subgroup analysis. So I think now both of us are little on different aspects. I think we need to clarify when we say a subgroup analysis, when are we going not to do it because we have not calculated the sample size on this basis? And when you do a subgroup analysis to look for certain factors which would have influenced the outcome, do you conclude based on this, or you just see the directionality that even in the subgroup analysis, if we remove those patients or we just subcategorize them, we just see directionality that our outcomes or parameters or the results are not changing, and hence we prove the whole group hypothesis in the right direction. So can you just conclude and clarify these aspects to our listeners?
Sure. Thank you. I think it's a very, very important question. I just want to introduce one more concept, something called sensitivity analysis. The reason I introduced that, we'll go back to the same example, right? Now, you want to be pragmatic and you will think that in the population that I'm studying, for example, breast cancer, more than 15% of them start with pain before surgery. Many don't appreciate. On the other hand, there might be a different case where the surgical condition may not have so much pain, or maybe a chest malignancy, but they're very prone to post-surgical pain. And maybe a few patients might have pre-existing. So your subgroup is not going to be big enough. So what you could do is, I'll do a sensitivity analysis where there is some noise. People understand what I call noise. Noise is where your data is otherwise clean, or you can say outlier, where something is not fitting the whole group, right? And then let me take out that noise and see whether my results are robust enough, or they may become even robust because you're taking out the noise, right? So that is sensitivity. And all of these, whether it's subgroup or sensitivity, you're not going to lose by clearly indicating beforehand what you're going to do. Whenever you do something after the fact, post hoc, which is wrong, because you already have an idea and that you're trying to play out. And then the more you play with it, the more you're going to judge. So that is not allowed and that should not be done. We should never encourage that. But in the truest of your minds, I mean, you know that things are not going to be as straightforward. So you put out some extra hypothesis, but and you have to know that these are all exploratory. Your sample size, suppose statistically, you have such a methodologist who says, you know what, let's do this primary hypothesis in alpha of this and then do an exploration with a certain degree of alpha. Maybe it's powered. But typically, all of these are exploratory hypotheses. What that means is you're exploring and giving out this so that either you can do this study or someone else can look at this exploration and say, okay, let's explore why this subgroup did this way and let us do another study. So these are all exploratory hypotheses. So lastly, I want to add is, as I said, a priori, subgroup hypothesis, even if you want, there are certain rules around it. When I say rules, it's not like rules on sand and you have to follow it. People, methodologists know that there are some simple principles around how to build subgroup hypotheses. You can't build 10, 15, as minimum as possible. One, for example, in all the grants, for example, CHR, which is like the Indian Institute of Medical Research here, Canadian Institute of Health Research, we are supposed to do sex and gender analysis as subgroup hypothesis because we know so many things work differently biologically in women and men. Okay. So like that, you can build certain hypotheses a priori, but you can't have so many of them. One. Second, you must have a clear clinical rationale. You can't just build a hypothesis like, people born in this star sign versus Gemini versus Zodiac Scorpio. No, I'm joking here, but people have done it to show that how ridiculous subgroups can work. Sometimes they come out statistically significant. So you have to have a clinical rationale. Third, you have to have a supposed directionality to it. You have to indicate a priori, I am thinking this will go in this direction. It will work or does not work. It may be possible for you to create an effect size. Sometimes you don't have, but sometimes, it can work this way, this much. You don't have to, but you have to have as minimal as possible. You have to a priori do it. You have to have a directionality and a clinical reasoning behind it. Simple ground rules.
Excellent. I think I was witnessing what looked like a nice debate, between top advocates or lawyers. And, it was a very enlightening, I would say, session, conversation, whatever we had. Now, it's been close to 90 minutes of in-depth discussions about research. Now, to just wrap it up, just one question to both of you. What tips to young researchers? How would you kind of, inspire the young researchers to take up research? And is there anything that will make their life easy? Dr. Rakesh.
I think I was just a couple of weeks back, somebody invited for a webinar, research for clinicians, research for private practitioners, research for freelancers. And I looked at session, I said, research is not only for researchers, and Dr. Harsha has emphasized in the beginning itself. Research is for everybody. Even in your clinical practice, when you read papers, you need to understand the research to apply to your clinical science. And hence it is important, and that's why if you see our NMC, they have made the research methodology workshop for all the postgraduates mandatory. And this is the reason that whether a person wants to just work as a clinician, academician, vis-a-vis a researcher, he should understand. Second aspect is, I again reiterate, research is not something very difficult. As we want to learn something new, we have to understand the basics, and those goes to the advanced. Same thing is for research. If you just spend few moments into it, it is one of the easiest thing. It requires a little time, a little dedication, a little passion about it. And I think anybody can become a good researcher if these attributes are there. Having said that, I would also advocate that researchers always works into a team, and everybody has a strength. Somebody is very good at statistics. Somebody is very good at methodology. He become a methodologist. Somebody is really good with their clinical experience, because even if we have data, even our data set is inputted into various statistical tool and they give us certain values, they have to be interpreted based on to a clinical experience. And that's why a clinician has also to be a part of researcher, so that he says, a difference of 1, what's big about me? A reduction by 10% of the dose, what's big about it? It's not going to affect my clinical practice. So those interpretation again has to come into picture. So let's have that team, and everybody puts into that research, whatever you want to do it. Have a mentor. And this is again important. Yes, I know Google is a big mentor for many of us. We can search so many things, but simultaneously, Google gives so much things which becomes difficult to understand whether they are correct or not. And that's where we require a mentor, a right mentor. Though people are nowadays looking towards the artificial intelligence and those models to mentor them for the right things. But again, we are not very sure that they will mentor you rightly. So pick up a good person. Maybe Dr. Harsha may be a right mentor for many of us, and he will agree to it. We can choose few of us, few of them who can mentor us, and then I think those who has a passion can become a good researcher.
You, Dr. Rakesh. In fact, the amount of good work that you've done for Indian Journal of Anaesthesia, the quality of research that is getting published now is commendable. And I'm sure we will see more good quality research coming out from India, researchers, especially the young researchers, taking cue from people like you. And Harsha, your thoughts about what, how few inspiring words I would call it to young researchers.
This itself is such a feat, right? I mean, all of this effort, what we're doing today, it's not from me, but I'm so glad this is coming together, or things like this now we see nowadays, and people can have available to this and get their knowledge or at least some inputs around how research happens clinically. So thanks, Murali, thanks, IJA, for all these efforts. Research is not hard, but as clinicians, being a clinician researcher could be a challenge. Now, I think we have to break it down. Simply speaking, research may be too much for someone, but why are you doing it? You have to understand that all you do on a daily practice, you go, you pick up a laryngoscope, you don't know whether to pick up a video laryngoscope, or you don't know whether you need a fiber optic. How do you do that? You're assuming on some statistics. You have some knowledge, you think that is the relative risk. That is, you might not be vocalizing it. That's what is happening. You put out the spinal, you did this, something else happened. Why is it happening? Are you not interested to know why your epidural failed? Why should you give 1.2 mLs for a cesarean section and why not 0.8 mLs? Well, that's a research question. So we make decisions on a daily basis where we have to be curious enough to say, okay, why am I doing this? If I do this, what happens? Now, how are you going to address it? Purely by knowing which works and which doesn't work. That is what research does. Now, if you are a clinician researcher and you want to become an academician where you want to publish, you want to be known as a researcher where you conducted studies, there are certain attributes that go with it. And everybody may not like it, but it's a very passionate field. I mean, if you're really passionate about this, there's so much to it. Failures are common because acceptance rate of an article, even Einstein's relativity publication did not get accepted the first time. It got published in a very odd journal. In fact, his most cited publication is a totally different one, not even about relativity. So people have to appreciate that failure in writing is common. And if you want to become a researcher or a writer, one thing is, don't read so much about introduction or discussion. Core of it is the methods. In fact, there are some journals, or if you see most anesthesia journals now, they fix a limit for introduction or discussion because the story goes on and on and on. It's a story. The story introduction is giving you what you want to do. The story discussion is what you just did. But what you did was not right, then you can ignore those two stories completely. Now, how do you understand methods is knowing what you're reading. Now, it's not me, it's not a particular book. Always try to have different sources. One book may tell you, okay, I don't know. Many people don't know why student's t-test was done. Student was a name. Student's t-test is a comparison for, continuous outcomes in a parametric distribution. People know about Guinness beer. People drink beer. And there is a company called Guinness. And this guy did not know which barleys would do well for his beer. And then he was a good mathematician too. He did his experiments. His other name was a student. There was a name for him, it's student. So as a conflict of interest, he couldn't put his name. So he devised this test called student t-test. Now, these are so many interesting things that you read from different books. And the more you grow your interest around such things, you'll understand you have to know this. And it's not difficult. Honestly, it's not difficult. Just to understand the methods, just to apply this in your practice, see what you're reading. It's not difficult. Yes, it might be a certain effort to become a clinician, academician where you do research. But for them, my advice is write. Just keep writing. People might accept it, but it will one day get accepted. don't worry about it. I mean, there is that hard work you put in, but if you're passionate to become an academician, know more about it, write and write and write.
Sarsha, now if there was any definition for a deep dive conversation, I would probably put this as the gold standard. As you said, it has been it's been 1 hour, 40 minutes of a very intense, deep discussion about various complex concepts of what research is all about. Thanks a lot for joining. I wish I was a postgraduate now listening to this, because probably the trajectory would have been different with what I would have done with my career. But thanks a lot for joining. And as we have more research coming out in the, I would say, domain of anesthesia, understanding how to read a paper, how to understand the differences between, as we mentioned, non-inferiority, pragmatic trials, different type of trials, different types of research is very important. So to everybody listening, thanks a lot. I mean to say, it's not easy to spend 1 hour and 40 minutes with us when you've got a busy life schedule. Thanks for joining us. And Harsha, thanks a lot from the entire IJA podcast team, the IJA team as a whole. Thanks for taking your time off in your busy schedule and spending such valuable insights. And for people who want to meet him, he will be in India once in probably a year or once in 2 years in various conferences. So you can catch up with him. Am I right, Harsha?
I love, by the way, this is a very interactive session, Murali. Sorry, I cut you off, but yeah, always happy to, help or chat.
Let's hope the research in India takes off in a big way after such kind of insightful discussions. So till the next episode of our IJA podcast, as we always say, stay curious, stay safe, and after this episode, stay and learn more about research. Thank you very much. Thank you, Dr. Rakesh.
Thank you
Harsha.
so much. Thank you.